All right, sarcopenia in the prostate cancer patient. Again, in the wisdom of Dr. Crawford, Mr. 30 years, he said we need something on this too, and this is great right after that great talk on exercise and the benefits of that. Anyway, if you want to use a quote in the Moyad house that has been used over 25 years, whenever I have a crabby kid or I'm dealing with some crabby student, I always go, look, man, you're just one workout away from being in a good mood. And then that gives them the idea of there's also these mental health benefits here we're just beginning to touch upon, along with the physical health benefits. And I knew today was going to be a great day getting a run in early this morning. It makes you feel completely different coming into the meeting. So really what I wanted to title this thing is No Death by Slides. This is my part 2 story. But you can't look at sarcopenia by itself without looking at the epidemic. They call it sarcopenic obesity or sarco-obesity, along with bone loss. They call it sarco-osteopenia or osteoporosis. But yet in some of these patients, including the ADT patients, there's no weight change. Let me explain that in a moment. All right, there's my AbbVie Speakers Bureau for Disease State Awareness on Promoting Wellness. That's my only disclosure. That's indirect at best, but we put it there anyway. So I'm going to discuss the prevalence of sarcopenia, clinical studies, limitations. Really, the whole point of this 10 minutes is what to say to patients about this if you got a couple sentences to give. If you look at the sarcopenia data, single center, retrospective, some of the most recent, the prevalence is extremely high. What happens is the moment you get testosterone suppression, the clock starts ticking. It starts ticking in 2 ways, 2 types of fats. Visceral adipose tissue, also called VAT, that's the deep types of fat that surround the organs that cause all the problems. But also what happens with testosterone suppression, right when it happens, the clock starts ticking and you start accumulating subcutaneous fat. Matthew Smith and others out there, they've looked at all this and made these clinical trials. So the best time to intervene, if you want to take home one thing from this message, is before the injection, before the surgery, before the pill is given. Because once you're 1 month in or 2 months in, it becomes a very steep slope, very difficult. The average BMI in prostate cancer studies, when I first came to this meeting almost 30 years ago when I was invited, was 25, 26. Now if you look at the average BMI in prostate cancer studies, including with LHRH, you're now talking about 28 and 29. So the average patient's BMI is now moving toward obesity. In fact, I talked about the meal study that Parsons did. One thing that didn't make JAMA or the headlines is the average patient in that meal study on active surveillance, these are active surveillance patients, was approaching 29 and 30. So what we have is a situation that's mostly described in women's health, but it happens in men's health. It's called metabolically unhealthy. What that means is that as a person ages or is subject to androgen deprivation treatment, you see bone loss and you see muscle loss, but you see fat mass increase. So if you're just using a scale, since bone and muscle weighs more than fat by volume, what happens is you get rid of 2 things that weigh a lot, bone and muscle. You add fat that doesn't weigh as much, and the person's weight does not change in the scale, but they are becoming completely unhealthy unless it's addressed. So don't let that just stepping on the scale make the difference. There's this new syndrome called metabolically unhealthy with the loss of bone and muscle and the gain of adipose tissue. And again, what I try to convince patients, clinicians, is that you have the perfect marriage here. You want to talk about a perfect marriage? People try to argue one or the other. Should it be aerobic or should it be a resistance training? They really are synergistic. So I love these in cardiovascular medicine that show they do similar things and they do different things. We see with some type of aerobic activity, some bone health benefits. We definitely see it in weightlifting. Strength we see with weightlifting. Cardiovascular changes on both sides. Mental health changes on both sides. But when one is done without the other, you really can't get the maximum benefit. And the other thing I want to talk about before I finish up with some other take-home points is that there's a huge movement and a lot of money being spent on taking pills to enhance exercise routines. And I understand that, and people get excited about that, but I want to put this in perspective. With this big pill movement, you have to talk to patients that even when it comes to exercise, we're learning that less is more. So in the past few years I've come to this meeting, there was a lot of interest on vitamin D. What this shows you, as vitamin D became very popular, patients started taking vitamin D supplements in large quantities in the United States more and more. So if you look in 1999, 2000, you're essentially looking at 1% of the patients in their 60s or 0.4%. Now you're up to 1/3, and I would argue that if you update this, which will be updated again in 2019, 2020, you're at 50% of people taking these pills. And the largest vitamin D trial just concluded this past year, but nobody cared about it, even though it was an amazing study. And the reality was they didn't show any benefit in the area of cancer or heart disease prevention. But there's one thing that didn't make the media, and that was if you look at the appendix, even though patients were taking just 2,000 IU of vitamin D supplements, there was an HR of 1.12 moving toward 0.08. In other words, is it theoretically possible at a time where people love taking vitamin D supplements and you add more vitamin D on top of that, even a small amount, you're increasing the risk of kidney stones? I think that's the case, but we'll see. Anyway, the other thing to answer to patients when we go to this whole idea of sarcopenia and pill taking is that we want to wait for data also to come out where you don't take an excess of anything. So the Australians did a trial in 2011, which was very fascinating to me because it hasn't been done again in men to my knowledge. You take 180 men and you randomize them to 3 days a week, essentially, of resistance exercise. And that helps with BMD. That's great. And then the other group, in this 180, they're split in half. The other group takes additional calcium and vitamin D beyond what you get in diet or recommended. So you take higher doses of calcium and higher doses of vitamin D beyond the recommended daily allowance to see if you get a better osteogenic response, and they didn't. So someone has to prove to me that taking high doses of calcium and vitamin D beyond what you get in diet today can give you some benefit in the area of sarcopenia or osteoporosis. I haven't seen it yet. And then the biggest breaking news, no pun intended, is this 3-year randomized trial that was done in Canada where they put elderly patients on different dosages of vitamin D, and they found out that the higher the dose over the 3-year randomized trial, the greater the bone loss. So this was so surprising to them that they started using words that I think the editors let them get away with. They said, only hypercalcemia and hypercalciuria was demonstrated a significant dose response effect. What do you mean only? That's concerning. That's concerning in urology. So maybe more is not better in terms of bone health, more is not better in terms of muscle health, and maybe all we're doing is increasing the risk of kidney stones. When I mentioned Matthew Smith, I love some of the work that he did with ADT because he also looked at just normalizing calcium and vitamin D intake in this large randomized trial of patients on LHRH. And after 24 months, there was only a 1% bone loss. I think David knows that in the old days, just going back 25, 30 years ago, we would memorize these massive amounts of bone loss that patients would experience on ADT, 5%, 3% per year, 8% from all these old retrospective data. But really, when you look at some of this newer randomized data, patients just getting a normal amount of calcium and vitamin D and not necessarily doing a whole lot don't suffer as much bone loss as we thought they would. And then there's always fascinations with pills and potions, but again, no real objective data here. Growth hormone I get asked about by a lot of individuals. A lot of patients ask about these potions. My favorite study on growth hormone was one that was actually published in 1994 that still gets a lot of attention. See, what you do in these studies is you put people on all these supplements or growth hormone up front, and then you claim all these benefits. What if you did it differently? What if you told men just to do 14 weeks of weight training, and then after they gain that strength and reduce their sarcopenia, then you would randomize them to 10 more weeks of growth hormone or not, no benefit. So this idea that up front when you give protein powder or something else, it looks great, but the really rigorous trials, in my opinion, would let men just do resistance exercise up front for 3 months, and then you can add this thing that's supposed to increase your muscle strength, and I'm not seeing many of these potions do that. They might increase muscle size, but not necessarily strength. Again, I go back to the heart healthy interventions. I don't care as much if metformin is going to be found ultimately to fight prostate cancer. What I care is that the secondary benefits have been extremely heart healthy. It's one of the only generic products proven to reduce the risk of type 2 diabetes. It costs pennies here in the United States now, and here's a trial of LHRH patients getting all these heart healthy changes when they're put on metformin with a little bit of dietary change versus placebo. The other question that happens with sarcopenia is maybe we could prevent it if men out there, when we put them on ADT, would increase their protein intake. So here's the current recommended daily allowance of protein. It's actually 0.8 grams per kilograms per day of body weight. So again, currently the recommended intake is 0.8. Right now, scientists are arguing that in patients on ADT, or when you cross 55, 60 years old, when you start seeing more muscle loss, should you increase that to 1 to 1.2? Put together outside of the metric system, I know us in the United States, like my 4th grade teacher told me I had to memorize the metric system because we were going to go to it any day now. That was a good prediction. But the reality is that the way to do this is to divide it by half your maximum weight. So if you weigh 200 pounds, divide that by half, that gives you 100. That's the maximum amount of protein you should be getting as a patient, 100 grams a day. That's a lot. So 150, then 75. So that's where the recommendations are moving to increase muscle protein synthesis in general, and I wonder if that's where it's going to move in ADT to help patients build more muscle potentially. This is not coming so much from supplements, this is coming from food sources. And I would also argue that the plant-based sources of protein, whether you're lentils and beans, nuts and seeds, the plant-based protein sources are now getting clinical trials, and I think ultimately will show that they can help with muscle development as much as the animal-based proteins is what I think they'll show. There was just a pilot trial of androgen suppression plus protein powder. This is whey protein, and so this is 37 patients in California, just published a few years ago in BMC Cancer, and just a little bit of resistance training, 3 days a week, in men on androgen suppression gave you all these benefits overall in just this short period of time. But they did not see an enhanced benefit of taking a massive quantity of whey protein powder. This is very, very preliminary. And then one of my more favorite recent ones, this is published in the past few weeks, is this study that was done in the UK. You take 50 patients, do 3 months, you combine aerobic and resistance training, not just do one or the other, and then you see significant outcomes in these patients. Here's the key. What this study did and the Australian group did that is showing profound benefits of resistance training in ADT is they're starting the trial at the first injection. They are not waiting month 9, they're not waiting year 2, they're doing these randomized trials up front in people who are candidates for ADT. Now, here's your take-home messages for your practice. No group has published more on ADT and LHRH than the Australian team. And what they tend to do is very simplistic exercises that can be done in very short periods of time, just 2 times a week, to reduce some of these side effects, including sarcopenia. So in most of their clinical trials, they just do 6 exercises, and I outline these 6. So it's 3 lower body, 3 upper body, 2 reps, 2 groups of each, and you can be done easily in 20 to 30 minutes. So chest press, seated row, lat pull down, and then 3 with the legs, the leg press, and then you do the leg extension, and then the leg curl. So you're getting not only the quads, you're getting the hamstrings, you're getting the calves, all areas of upper and lower leg and upper and lower body. It doesn't take 8 hours a day or 1 hour to do all this stuff. It takes a very short period of time based on all this data from Australia. A couple more quick questions. Less is more. Yes, what does that mean? Right now they're studying this idea that you don't have to keep increasing the weight in order to increase the strength. When I grew up, we were told that as you became stronger, you needed to increase the weight, and then you needed to do more reps with heavier and heavier weights. But what if you actually used lighter and lighter weights, but just did more repetitions to exhaustion? 30 to 50% max versus 75 to 90%. So far, at least in younger individuals, they've seen no difference in muscle strength and size. So less is more is equal to more is less. And the other thing you can tell patients, especially we deal with a lot of elderly patients, is this idea of increasing weight. And increasing weights as you get stronger just only increases the risk of injury. So just doing a lot of reps at lower weights reduces injury and still gives you the same outcome, we believe. And then I was also told as a kid that you had to let your muscles rest a few days before you did another session of weightlifting. It turns out that might be BS also. No one's got time to just figure this all out. I like to lift on the weekends when I have more time. So it's consecutive versus non-consecutive resistance exercise. They had people go 3 days a week consecutively or break it off by 24 hours, and there was no difference. All right. I promise to finish this off, and the only other thing I want to say is we're also watching breast cancer because they just published a randomized trial of resistance training to reduce hot flashes. The theory in breast cancer is the more intense the exercise, the more you secrete these factors that can help control thermoregulation. And this was just published in postmenopausal women. There's another trial going on in breast cancer patients. So maybe we should also be recommending resistance exercise to reduce hot flashes. It was already mentioned to reduce fatigue. This is a big meta-analysis. It worked better than the drug treatments to reduce fatigue. And I always tell patients, if you don't combine your exercise with your pills, then you don't make the pills work better. Here's a classic example of people who exercise and are compliant with their pills tend to do better in clinical studies than people who are not compliant or don't exercise. Here's your take-home messages for your practice. Sarcopenia, aerobic and resistance exercise with diet prevention program, all of this stuff, the diet talk, the sarcopenia prevention talk, the resistance exercise twice a week has to happen before suppression. Otherwise, the visceral adipose tissue and subcutaneous tissue accumulate too quickly, and it's difficult to get rid of that. It's not just the physical health benefits with exercise that you should sell. You should sell to patients the mental health benefits. I have found nothing better to reduce what I call SAD, stress, anxiety, depression. Also, what I also call SI, suicidal ideation, because you reboot the brain, and catastrophizing, which can happen in cancer a lot, where you go down a negative pathway and you think everything's going to go wrong when you get bad news. It takes you out of that moment and reboots the system. So it's the mental health benefits that should be talked about as much, if not more, than the physical health benefits. Less is more in terms of weight is less injury. You don't have to wait every 2 to 3 days to lift weights. The suggestion is if you have 2 days in a week and it's Saturday, Sunday, that's good enough. 2 to 3 times a week has been plenty in clinical trials to show benefits of bone, muscle, in terms of weight control. There's one more important point I want to mention here. Many of the clinical trials in ADT and other places and all of exercise show far greater benefits when people do socialized exercise versus isolated exercise. So tell patients if they can get a trainer, if they can go with some people in the support group, you tend to get better adherence in clinical trials with socialized exercise versus isolated exercise, working out with somebody or with a trainer. People still want to take amazing pills, placebos, nocebos, protein bars. The only thing you should get from a bar is a beer. I'm not a big fan of all these protein bars out there that add a ton of calories. You can get this amount of protein from a lot of healthy food. And since this is my last talk of the day, I want to give one more kudos to Dr. Crawford out there, but he left the room, so I'm not going to give him that kudo, but 30 years, yay. Thank you very much for your time. I appreciate it.